Last case, we got to go back to work. So Fadi, this is yours. So let's go back to our first patient, symptomatic metastatic unresectable disease. Make them RAS mutated, so it was a KRAS mutation. Frontline got, Folfox Bev, actually stayed on treatment through 6 months of initial therapy, maintenance of choice until about 10, 11 months, progressed, still had a little neuropathy, went to FOLFIRI Bev, second line, and was on that 4 or 6 months, something like that. Not really that symptomatic, but CEA rising, new lesions seen on scan. What are you, about 18 months in at this point?
Well, did better than an average KRAS.
That's right. So where are you going now? How are we going to manage this refractory patient, liver, lung disease?
Unfortunately, we see it with the KRAS or NRAS or the RAS mutant patients. In my experience, it's even more dramatic story than this. They progress quickly. They have excellent performance status. Do we have any interest at recycling any of the cytotoxics? I have tendency not to do so because there is no data to do it, especially if the patient have received their 2 lines of anti-angiogenic. In this case, you gave Bev. Of course, they had the option to go Bev, after that to go ramucirumab, or now that we have it, or if I like Zif aflibercept, in second line, especially that the patient looks like they did a really good 11 months with the frontline Bev-based regimen. Again, it's all judgment. There is no absolute data to pursue it. But this patient is landing himself for the regorafenib to go. Yes, maybe we can do some molecular profile to see.
So is this a guy you go after in biopsy again?
Absolutely.
Yes.
So this is who we're certainly going after a liver chunk and sending it.
Yeah, absolutely.
We have a study doing that where we get biopsy and put them on regorafenib, knowing that we're going to need something else.
And speaking of biopsying, this patient may have been 3 years ago, had maybe just a PCR for the KRAS. We didn't do the next gene sequencing profiling. And that's another advantage of, in 3 years' times today, the technology of profiling, I call it for my patients molecular autopsy of your tumor, is a different status. We have much more markers, you can look at that. This patient may have not looked at the microsatellite stability. I may be, adding it now, and for the sake of clinical trials, maybe considering one of the checkpoint inhibitor. It's interesting, all of us, the way we were practicing 2 years ago, it's different than what we're practicing today because things are changing, at least when it comes to plugging them in clinical trials. If that's 102 is an option, let's say clinically extended access program, this patient would have qualified for the extended access program based on his performance.
Well, we've been running 400 gene profiles for a while, and we're getting to the point where we're doing whole exome for about a little bit more. And
what are you learning from all that? So
right,
people
so
who don't have all of that.
If you have a KRAS mutation, you're probably not going to find another actionable mutation. That's the reality. 9 out of 10 times, you're going to do it.
P53 and
right, and APC mutation. Even PI3 kinase, we don't have drugs for that yet today. I mean, we like to do it because we've got a bunch of phase 1 trials where we can kind of steer people. Maybe when the match suite of agents comes out, there'll be more reason to do it. So because there'll be an occasional actionable mutation. But I think we have to face the reality that given the drugs at our disposal today, most of the time you're not going to find the magic bullet.
Yeah, and I just want to make a point about biopsies and molecular profiling. This is not a perfect science. We talked a little bit earlier. Quality really matters here. Tissue acquisition, adequate samples, labs you trust doing these kinds of things.
Whether they scrape the tumor or they do microdissection.
So they're not all the same. And we saw that at this meeting there's a study of HER2 positive colon cancer. We're looking, the more we're looking, we're finding 5-something%, a little bit more in some series that are HER2 positive with some positive benefit. We're in our world, we have 3 fairly big centers that have clinical trials, so it's a broad portfolio of options if you find something that's kind of funky. So we're profiling, looking for something. Should this be standard? Should insurance pay for this?
So I believe it should. The interesting thing is that there's data from a recent JCO article that that not all oncologists are that great at interpreting these tests when
That's
they
the
come
problem.
back. And I have to say that I count myself among them. So we have a precision tumor board. Samik Rai-Chowdhury, who's one of our junior faculty, makes it his business to be aware of clinical trials all over the country. And he'll come back and say, you know, Novartis has got a drug for this mutation, or Pfizer's got a drug for that mutation. And it does take help for us to
We got
know.
to teach each other. We got to learn.
the way
And we
to
got to
do this.
share outcomes too. I think, you know, it's
Yeah.
easy to say, all right, this mutation, we should try that drug. But it's so important that we're collecting what happened to that patient. Because until we do that, all of this is just speculation.
Absolutely. A patient who responds well, there is an answer in that patient. Now, with the initiative of N of 1 reporting these patients, it's important. We're presenting at ASCO the signature studies of Novartis, you know, about finding actionable mutation. Actionable mutation doesn't mean necessarily good outcome. You know, we are being very disappointed. In fact, histology matters because it's like the BRAF story in melanoma. Yes, actionable mutation, you can have an impact. In colon cancer, it has been disappointing. So we're going back not to be tissue agnostic like we were dreaming 3 years ago, like tissue doesn't matter, because things are much more complex. You know, it's humbling. It's more complex than what we...
The more we test, the more we learn.
Exactly. But still, testing, I think if for the physician in the community, if you're testing, especially if a test that costs anywhere between $5,000 and $15,000, if you don't have an action on it, at least a clinical trial, especially phase 1, that you plug your patient in, don't do it. Now, if you do it for the sake of referring a patient to a center where there is a phase 1 study, yes, do it. But do it for the sake of just to get your KRAS and RAS status, and maybe it's a bit overpriced.
And why don't we just, I mean, if we're already doing RAS and MSI, aren't we at a place where let's just do it?
Yeah, I think you definitely need RAS and you need BRAF. So I think that the additional cost by the time you've already isolated the DNA is not that, the incremental cost is not that great. It should be done. I think that there's a problem with some of the reporting. Most of us do rely on the reports we get back from whatever company does it. I think many of them do a good job, but many of them give you incomplete data. For example, if they see KRAS mutation, they say trametinib. That doesn't work for colon cancer. And if half the people are getting trametinib, that would be kind of a sad use of our resources. So, you know, we need to really up our game a little bit in terms of what we do with these, with this information.
How we collect them.
Absolutely. The analytics is really crucial, and the report and interpretation of the report can be misleading, as you said. And last but not least, I want to be very careful, something that we're talking about. I see physicians, you know, these are somatic mutations. Yes, there is always the intriguing question, is it a watered down germline mutation? I had cases of colon cancer with the BRCA mutation. Ultimately, it's a germline mutation. But be careful, if you find a P53 mutation, don't go test for Li-Fraumeni syndrome every patient. No, so there is an interest of identifying germline mutation in a certain subset, and this is a research question we're dealing with. But we need to increase literacy about genetics and do not waste resources on testing for FAP and Li-Fraumeni every time you see P53 and APC somatic mutations.
So I'm going to wrap us up.